Dr. Mounika Koushal. I'm consultant neonatologist, consultant pediatrician, and head of the Department of Pediatric and Neonatology, Emirates Specialty Hospital. I'm also a medical director in the hospital, and my passion is neonatology, and I'll be taking you a tour of what we do here. Before that, I would like to tell you about some of my trainings. I did my MD from a very prestigious institute, PGI Chandigarh, and I did my super specialization from another prestigious institute, that is All India Institute of Medical Sciences, New Delhi. And after that, I had been privileged to be doing a fellowship in UK, and then I did my diploma with honors in UK Southampton. And actually I'm here past 17 years taking care of tiny small babies in level 3 tertiary NICU. So what all we do in our NICU, what all facilities we have in our NICU, I would just take you along to let you know that how passionately we are actually taking care of your small little ones who are coming to this world and facing certain problems, and before parents can take care of them, we do take care of them to give them a second life so that they should be with parents healthy and happy. So whenever we have a baby who is to be born premature or whom we know is going to be sick, we have to bring that baby to the NICU from the labor room, which is in the same floor. So we have this very high tech transport incubator in which we bring our baby with all the facilities. It is attached to a pulse oximeter, there is a ventilator, and we can put the baby on the ventilator, we can put the settings. It's kept warm because we preheat this incubator so that the baby, when he arrives in the NICU, should not become cold. Temperature maintenance is very important, airway maintenance is very important, and also we need to know what's happening to the baby throughout our transportation. So we have all the high-tech transport incubator with us, which can also be taken if we want to transport the baby to the radiology for CT scan or MRI, or if we want to transfer the baby to the OT if the baby needs any kind of surgical intervention. So this is a high-tech incubator which will keep the baby as good as inside the mom's womb. So when we have to take the baby inside this, or anytime when we have to enter, as you can see, it's a very restricted area where only people who are authorized to enter can enter, and hence we have a lock code which only we know, and if anyone else wants to enter has to press the bell where they can see us from the camera, and if they feel that we are the ones who are required to enter, they will open the door. Open the door and I can enter inside. So here we are in our NICU, and as we enter our NICU, what we can see that we have a nursing area, and the nursing area is designated with our very dedicated nurses. This is our head nurse, Lizzie, and she's taking care of overall in charge of the NICU and all the nitty-gritty whatever happens day to day. We have a multi-central channel monitor where she can sit here and have a look at all the babies' data, what are their saturation, blood pressure, what is their vital signs. Everything can be seen in this central multi-channel monitor. And before we enter our NICU, what we need to do is we have to have a strict infection control measures, where we have to put our masks, we have to put our cap, and we have to wash our hands in our hand washing areas. Hi, so we are here inside our NICU. This is a level 3 NICU, and it is a 14-bedded NICU where we have dedicated nurses for each baby. I'll just go through what we have in an NICU to look what's going to happen if your baby is in the NICU. So we have incubators, which are giraffe incubators, which can, when we require to do certain things, We can open them up so that it is easy to have an access, so that we don't have to move the baby here and there. And the temperature is well maintained in the incubator. So also we give a humidity inside the incubator so that the baby doesn't lose water when it's being a premature. I'll just take you to one baby who is a critical baby over here, so that you have a feel what all intensive care we really do. So here we have a baby who is 25 week and he's 600-700 grammer. He is born quite premature, and the reason why the baby is here is because the baby is quite sick and the baby requires lot of intervention. So what do we have here? We have an incubator where we keep the baby warm. We provide 70 to 80% humidity to keep the baby not losing his. So I'll just give you a glimpse about a very tiny premature baby, so that you can know what exactly we can do in our intensive care unit. So we have a 25-weeker who is 600-700 grammer. He is born before time because of leaking and infection in the mom, and the baby was born limp, so we had to bring in the tube in, and we brought to in our NICU. So in ICU, what all gadgets the baby is actually using? So baby is in an incubator which can be turned into a warmer whenever you want to do any procedure on the baby, so without actually fiddling with the baby. This incubator gives around 80 to 90% of humidity in the first week, and then we start reducing the humidity depending on the maturity of the baby's skin. So we have an incubator which is a very high-tech incubator, which monitors the baby's temperature and increases the heat or decreases the heat depending on the demand of the baby, so that the baby should not be having a temperature which is higher than normal, nor the baby should have a temperature which is below the normal. The baby, because is not able to breathe, is on ventilator, and we have a very high-tech ventilators here. So this baby is on dragger ventilator, and the baby, the dragger ventilator has all kind of ventilation options. So to begin with, we had to put the baby on assist control ventilation, but because the baby did not improve on the assist control ventilation, we had to shift the baby on a maximum highest mode of ventilator, which is high frequency ventilator. And this dragger, what we have, has a latest technology where along with the high frequency ventilation, we can also control the volume, so that the baby's lungs don't get injured because of the ventilation. So this baby is on high frequency ventilation along with volume guarantee, and that's why it is giving a very gentle kind of a ventilation to the baby, the gentle ventilation for the lungs of the baby. Along with this, unfortunately, this baby had a severe PPHN, which means its pulmonary pressures are very high. Usually this is a problem for term babies, and it is not easy for the term babies also to deal with this kind of a problem. And for a premature babies, we are left with not much medications for dealing with this. So of course, because there was a respiratory distress syndrome, we gave surfactant. Surfactant is a medicine which is given to the lungs because the baby is not mature and it's not producing surfactant to keep the lungs open. So we gave surfactant, and we in this baby, because the lungs are pretty bad, so we had to give 3 doses of surfactant over a period of time to maintain the oxygenation and the carbon dioxide. But because there were fluctuations in the saturations and the saturations were not picking, so we thought of PPHN and we did an echo from our echo machine, and we found it was a severe PPHN. Now, as I said, it is very difficult in term babies also to deal with PPHN, and it becomes almost impossible to deal with PPHN in premature babies, because the medications which are actually helping a PPHN of term babies, they do not really help in our premature babies, and the evidence is not showing much what can we use and what we cannot. However, if we follow the case reports of the globe and the Europe and US and Australia, they have tried to use nitric oxide in the premature babies also. So here we have a machine which we tried on our baby, and we actually put the baby on the nitric oxide along with high frequency ventilation. And both the machines did miracle to our baby. And from a very sick baby who was not maintaining saturation, only 70% or 80%, we could bring up the saturation to 95-97%. So these are the gadgets which are available to us, which we should know when to use, how to use to make the baby come over it. And then of course there is invasive blood pressure monitoring with us, because these kind of babies may go into hypotension, and if we monitor the blood pressure only non-invasively, we will not know if the blood pressure is right or not. So we put a arterial line, invasive arterial line, umbilical line along with the venous line to monitor the blood pressure, and depending on that we give the babies inotropes. So we look at the baby, we look at the blood pressure, we do a echo routinely, and then we decide on the inotropes. So this baby was on adrenaline inotrope because his blood pressures were not maintaining, and hence we had to start that, looking at everything together, and then the baby was quite okay. So we have a multi-channel monitor which will monitor the blood pressure, which will monitor the vitals, which will monitor the temperature, and it can help us to take care of the baby time to time. And then not only that, we have dedicated nurse who is going to monitor this. We have a dedicated doctor who is going to be 24 hours here to keep a close monitoring and then check the baby time to time. So here we have a team, dedicated nurses, and we have a very dedicated and very cooperative cardiologist, Dr. Sameer Sajwani, and we are all here as a team to take care of your baby as our baby till you get the baby back. We are here working together along with you, and we are a family centered NICU where we want the involvement of the mother and the father all the time. You are welcome all the time in the NICU, and we want the mother to be with the baby 24 hours if possible and take care of the baby till we take care of them and give back to you. You are welcome.